There's really, I think, basically one important point in this, which is that a TIA is not what we used to think it is. So what is a TIA? How do you define it? A reversible neurologic deficit. Good. So it's something where somebody has a neurologic deficit that seems to be explained by a vascular etiology. That is, it fits some sort of vascular pattern, and it gets better. How fast does it have to get better? 24 hours is the traditional definition. How fast does it really get better? Well, for the most part, people think that it gets better very quickly. So traditionally, the notion was it was like unstable angina. It was a neurologic deficit in a vascular territory where there was ischemia producing the neurologic findings, the clinical findings, but there was no infarction, and therefore it reversed. And usually when that happened, it was because whatever was causing the ischemia disappeared in a very short period of time. So you can imagine you have a little clot, it causes obstruction, you get ischemia, dysfunction, but then the clot breaks up, it goes somewhere distal, it's no longer obstructive, and now you have a return of function. In general, that was thought to occur within minutes in a lot of people, within an hour in a fair number of people, and then a few people would go out as late as 12 hours, 24 hours. So the definition was reversible in 24 hours. Like everything else, that definition is wrong in several important ways. One is that it really isn't just ischemia. That is, it might be in some cases, but in a lot of cases it's clearly a small stroke. But other areas of the brain are quickly recruited to do the job what the old area used to do. So you get a little bit of tingling and numbness in your hands, and then somebody else takes over and it comes back. Why is this important? Well, first of all, it's conceptually important. It tells us that the mechanism may be a little different than we thought it was. And second of all, it may have some relevance in terms of what you do about it, or what you could do about it. But let's first go back to how quickly it happens. It is referenced in here. There is a reference to the NASCET study, 603 TIAs. This was reported in, I think, 2003, and the median duration of a TIA was 15 minutes. Median means half more, half less. So half of them got better within 15 minutes. You've all seen this, right? Lots and lots of patients who had a very brief duration of problems. About 3/4 of them, just under 3/4, lasted less than an hour. Why might this be important in terms of TPA? We're going to talk about TPA tomorrow, because if, in fact, you can be pretty comfortable that a TIA is going to resolve in the first hour or so, when you're almost never seeing the patient, if they still have a deficit by the time you see them, this suggests most of them are going to have a completed stroke, not just a TIA. That's what this suggests. Now remember that all of this is a little bit fuzzy. First of all, some of them last longer. Second of all, completed strokes all get better too. Some of them get better over months, but they get at least partially better. Some of the TIAs and strokes, you know, they look mostly better. They're 100% normal, but there's still a little tiny bit of fuzziness of speech. Is that normal? Is that a TIA, or is that a stroke? Because there's a little tiny bit where there's a little dysarthria. And remember, even in the old definition of TIA, there was something called a reversible ischemic neurologic deficit, which is a TIA that lasted more than 24 hours. So obviously, this is not one entity. There's several. You can have a clot that breaks up and have just ischemia, but you also can have these small deficits that mostly or completely get better in a variable amount of time. Just to make it a little more complicated, I'll mention to you, not included in this chapter, is an article by Weimar from the Archives of Neurology in October of 2002. More than 1,000 TIAs, a very big study. 3/4 of them lasted more than an hour. Just the opposite of what the other study said. And not only did 3/4 last an hour, 3/5 of them lasted more than 2 hours. That would be really important. If you're thinking about using TPA and you only got 3 hours to do it, means you've got to get everything pretty much started by 2 hours. You can't be done unless you get started by 2 hours. If 3/5 of the TIA last more than 2 hours, then you have no idea when you're seeing them, a candidate, whether they're a TIA or not. So anyway, it's a little complicated. Now, more important than that, so I think it's worth thinking about that a TIA is a little different than we thought it was, with just a brief little thing, and it's clearly a totally reversed deficit. That's not the case. Probably is, in many cases, a small stroke. Oh, by the way, the other thing, of course, is, as we've talked about throughout this week, now we have better microscopes for looking at these things. If you get a regular old CT scan in a TIA, you don't see anything. If you get a CT scan in a small stroke, you don't see anything. In a large stroke, you mostly don't see anything in the first couple of hours. But if you get an MR in a stroke, you see it right away. Well, if you get an MR in a TIA, you often see a small stroke. You thought it was a TIA, but it really is a small stroke. So what does this all mean? Why should we care? Well, the next series of articles, up through 8, are all about what happens if you have a TIA. And what happens? You got better very quickly. One of the articles says in 15 minutes, one says an hour, one says 3 hours, but you got better, okay? You're all better. What happens next? Well, the most important article is number 5. All the others basically say the same thing as number 5, but number 5 is the really famous one. It was done by Johnston. It was in JAMA, and it's from Kaiser in Northern California. Kaiser is an HMO which really has done a tremendous amount of good health services research. Kaiser is interested in saving money, so it wants to send people home. But it also has always been very responsible in terms of how it makes decisions for its group. So it first wants to find out, are we doing the right thing? So number 5 was asking that question. What happens to patients with a TIA? 1,700 patients diagnosed in a Kaiser emergency department. By 90 days, 10% of them had had a completed stroke. 1 out of 10 in the next 3 months. Half of that group, or 5%, had their stroke in the first 2 days after the TIA. That's 1 out of 20. Means 19 out of 20 will be fine 2 days later, but 1 out of 20 will have a stroke within 2 days. This data has been repeated in all of these other studies, and they all come up with very similar numbers. Why is that important? Well, think about unstable angina. Unstable angina we worry about a great deal, right? Much fewer of those go on to an MI in 2 days. This is a big, high-risk deal. Those strokes tended to, 85% of them tended to be big, disabling strokes. What should we do with this information? Well, here's what Kaiser did. The first thing they did was they said, we are no longer sending home TIAs, despite their interest in saving money by not hospitalizing patients. So they said, you can't just treat this as little. Some of these patients are at great risk. And that seems to all make sense. But it does beg the real question. So once you put them in the hospital, we all know a hospital is a really safe place. It protects you. What do? Yes, they're at risk. Yes, most of them do fine. Occasional one does terribly. What do you do about it? So that's several of these articles address that question, and they talk about what's the appropriate emergency workup for a TIA. And if you think about it, it should be to find and allow you to treat a reversible cause of a stroke. So what are reversible causes? A mural thrombus on the heart. What else? AFib is the big one. AFib clearly is the one we can do something about because we don't even know what to do about a mural thrombus. What else? Well, you could find a critical carotid disease, but are you going to have time to do carotid surgery the next day? It's not really clear that identifying most of these makes a difference. And AFib is the one we always knew about, and we could always find right there just by putting our finger on their pulse. So AFib is the important one, but despite a lot of attention paid to this, I'm not sure it really changes very much of anything.
Kaiser doing the logical follow-up study, which is, does it make a difference to hospitalize?
So is Kaiser doing the logical follow-up study? I don't think so, and I don't really know. But I do think, but here's what most everybody says if you want to be rational about this. So a lot of people started hospitalizing patients. Remember, 15 years ago, TIAs all got hospitalized, up until maybe 15 years ago. Then they all got sent home, or a lot of them got sent home, and now there are a lot of people hospitalizing them again. How many of you are hospitalizing TIAs? A lot. If you're not going to hospitalize them, what must you do? You better do this workup, the appropriate workup, and you better do it time appropriately. What's time appropriate? Oh, by the way, of those 5% who have it in 2 days, probably half of them have it in the first day. So how much time do you have? No time. Now, you can sort of beg the question by hospitalizing the patient. That doesn't get it done. But from a legal standpoint, it sort of gives you a fair amount of safety. Certainly, it puts it on the burden on the neurologist if you're admitting it to a neurologist. But what a lot of places have started to do is say, you cannot go home unless we can do the appropriate workup right now and then send you home. What's the appropriate workup? Look for a fib, do an echo to look for a mural thrombus, and do a carotid duplex exam. Now again, I'm not convinced at all that that's going to change outcomes. But it's what people believe you have to do if you want to say it's safe. Do we do it? No. There's one of these studies which looked in Ontario. I think it's number 5 or number 6 or number 7, which it's 8. And it basically says that despite all of this, and despite the fact that there's been similar papers about what TIA is like, which you have it here from the same group, in the community, nobody's doing anything. They're sending people home, and 30 days later, they're getting the workup. 30 days later, you don't need the workup, because either you've passed or failed by then, to some extent. The other question is, can you predict from all these TIAs which ones are at the greatest risk? And the answer is yes, you probably can predict. Although these studies are bad in terms of methodology for doing that type of prediction, I'm not going to tell you why, but you really can't tell from these studies. They do seem to have the same observation in each of the studies, which is the patients who go on to have the subsequent stroke, and particularly the bad subsequent stroke, also had a particular type of TIA. What type of TIA? A bad TIA. The longer it lasted, the more risk you're at. The denser it was, if you had actually had motor findings and sensory findings and speech findings, as opposed to just I had a little numbness in my hands, or a little bit of, not right, or a little confusion, or a little posterior fossa stuff. The bigger the TIA was, the more the risk was. But that isn't even the right question, is it? The question should be, is there any TIA where you're not at risk at all? And the answer is no, there are none. Some of these patients go on to a big stroke. By the way, we're talking about a first TIA. The more TIAs you have, ironically, the less risk you have that the next one's going to be a stroke, unless you're having what's called crescendo TIAs, where they're having a bunch in a row. But if I had a TIA 6 years ago, and then I had one 4 years ago, and then last year, and now I have another one, the risk is relatively much lower than if this is your first TIA. Still, it's not zero, so I don't know that it makes a decision point for any of us. The last thing to say on this is article number 7 looks at it just the other way around. It looks, instead of at TIAs, what happens to them, it looks at strokes. How many of them had a TIA? And it's basically the same data from the other point of view. Almost a quarter, 23%, had a recent TIA in the last month of people who came in with a completed stroke. In that group, 17% of that group, or 4% of the total, their TIA was the same day as the stroke. So again, just to remind us, this is a pretty high-risk diagnosis. Now, what's the advantage of putting them in the hospital? Well, you might be able to do the workup quickly. What's the disadvantage? Besides, it costs a lot of money. When they have their stroke, they'll be in time to get TPA. That is, as far as I'm concerned, we'll talk about TPA tomorrow. But that is actually one of the reasons why people who are believers in TPA believe you should hospitalize the patient, because you'll have them right there if something happens. I'm not sure that's a great idea. That's really what this chapter is about. It's a simple observation that's happened over the last 5 years. TIAs ain't what we thought they were, and they're really dangerous. Now, there is one little other thing in the chapter that I'll just mention to you. It's not terribly important, and we don't really know the answer. 9, 10, and 11 ask about Plavix or Clopidogrel. How many of you know of any patient who is not on Plavix? It is a remarkably good-selling drug. I see a lot of patients on Plavix, especially cardiac patients on Plavix, on Clopidogrel at UCLA. And, it's hard to know because some of the studies say, oh, it doesn't cause that much bleeding. But the medicine residents have a name for it, like, I forget what it was, a catchy name about how much it bleeds. And I see bleeding all the time on Clopidogrel patients. Cardiac surgeons refuse to take a patient to the operating room if you started them on Plavix. I think that's almost universal because it causes so much bleeding. So I don't know how people are measuring it, but it seems to me like it's a drug with a great deal of bleeding. This question is, should you use Clopidogrel instead of just aspirin? We know that aspirin is important for TIA just as it is for stroke. How important? Well, it's not life-saving. Well, 1 out of 100 benefits. 1 out of 100 less strokes, 1 out of 100 less recurrent strokes, 1 out of 100 less deaths, 1 out of 100 less disability. This is based on huge amounts of information. Unlike the rest of the stroke literature, there's a great deal of information about aspirin. So aspirin works. It clearly works. In every big study, it works at about that level. It doesn't do great things, but it does a little. What about other antiplatelet agents like clopidine and dipyridamole and Clopidogrel? So these are 3 articles about Clopidogrel. The first one is very clever. It's by the makers of Clopidogrel, and they compared. It was a double-blind study, Clopidogrel alone or Clopidogrel plus aspirin. That's brilliant. I don't know anywhere which says the standard is Clopidogrel. Shouldn't it be aspirin alone or aspirin plus? You can't lose this way. Turns out the combination wasn't better than Clopidogrel alone. It's hard to lose if you're the manufacturer. Well, I guess we should use Clopidogrel alone. How about should you use Clopidogrel instead of aspirin? Number 10 and 11 are an argument. One person says, use Clopidogrel with aspirin. The other one says, don't use it. I'm not going to go through their arguments. They both refer to a lot of the literature, but the biggest study, which was by the manufacturer, showed a 1% benefit in the combination compared to aspirin alone when you use both of them together compared to aspirin alone in a TIA, and that was for for this category that they called vascular events. But if you actually looked at strokes and MIs, which are the only 2 important vascular events that I know, they were exactly balanced. There was a slight increase in stroke, a slight decrease in MI. The type you'd expect, where the differences were so tiny, you'd expect them to be just by chance. So I personally don't think there is any evidence in favor of using this combination. And that's what the number 11 guy concludes as well, but I don't really know, there's going to be a lot of push to use this, and a lot of people are. There is some evidence in the past that if people have recurrent neurologic events while already on aspirin, you may get some extra bang by switching them to a different agent. But it isn't clear. And that was only done for ticlopidine. It's not been done for the new kid on the block, which is Clopidogrel. Anything else to say about that? I think that's really basically it. Oh, by the way, one of the things in here you'll read, it says dipyridamole has no role in treating TIA patients, but the combination of dipyridamole and aspirin relatively looks better than the combination of Clopidogrel and aspirin. So it's, aspirin is the mainstay. So what should we do if you see a TIA? For sure, you must put them on aspirin. Low dose aspirin? Low dose aspirin, 1 regular aspirin. Nobody knows the dose. Aspirin is, like, who knows? Wave an aspirin near them.
Could you comment on if you choose to commit TIAs, use heparin and not those patients, whether it's
should you use heparin in AFib patients or non-AFib patients? So we just did a study yesterday. We did a tape next door yesterday, or in the back of the room here. And we did a study where somebody looked at, they've been unable to find a utility for heparin compared to aspirin in TIAs at all. So they went and looked at the literature, and they sliced and diced every way they could. And the title of the article was, is there any patient who benefits from heparin in TIA? And they looked particularly at the patients who would be the best candidates, like AFib patients. And they found there was no subgroup where it was useful. All heparin does is increases bleeding risk. This was based on, we've always done it. We've always known it's the right thing to do. How could it not work? There's got to be somebody it works in. And the conclusion was, we couldn't find anyone. Now, the study wasn't a great study, I got to tell you. So there may be some subgroup in whom there is benefit, but so far we don't know who that is.
Our cardiologist will not convert an AFib without anticoagulation. And that's why they hospitalize the patient.
So the comment was, what about converting an AFib? And the cardiologist, well, that's actually an interesting thing. It is clear that if you have new onset AFib in the first day or so, the risk of a stroke is very, very small when you convert it. Remember, with AFib, when do you get a stroke? At the time of conversion. That's the most likely time. If you're in AFib for a long period, over time, you have an increased risk. But the acute risk for any one 12-hour period is by far worse when you convert. So the comment was, the cardiologists don't want to convert the patient unless the patient is anticoagulated. That's basically a very good idea. On the other hand, if you have very new onset AFib, it just went in, it's very unlikely to cause a stroke. So there are a lot of people who say, well, if it's less than 3 days, you don't have to heparinize them. By the way, the risk isn't zero in the first couple of days. And by the way, the only evidence we have is it doesn't look like heparin decreases the risk in the first day, because the heparin isn't really fully effective. So it's a mishmash. Again, that's not an inappropriate thing. But for treating the TIA itself, there is no benefit to using heparin.
A lot of patients don't know they have AFib when they come in. They may have had a pre-existing AFib. That happens all the time.
Yeah, and how do you know? So many patients, you don't know how long it's been going on. And so it is reasonable if you're thinking, I'm going to convert this AFib, you must heparinize them, absolutely. But that's not different than I'm treating the TIA with heparin.
Any thoughts on how to handle the patient who has a TIA while on aspirin?
So what do you do with the patient who has a TIA and aspirin? Yes, I have thoughts, but there is very little in the way of evidence. The evidence was, there's one article from 15 years ago which said you get a small incremental benefit in terms of risk of recurrence and strokes if you switch them to another antiplatelet agent. The antiplatelet agent in that case was ticlopidine. I don't remember the study well enough to tell you whether or not it was flawed. And there are simple ways of making these very flawed. But there was one study which said if they failed aspirin, ticlopidine is better. And it was sort of an observational study. I just don't remember the details. Seth.
Corollary to that, the patient now is probably on Coumadin because of another reason. What's the risk of adding aspirin to Coumadin? And that always sometimes comes up with also ischemia, cardiac ischemia.
So what about if the patient's already on Coumadin? What's the risk of adding aspirin? Traditionally we're told it's a real big no-no. I don't really think there is data on that. I really don't think there is data on whether or not a single, my general rule is a single aspirin is not dangerous. It makes no difference. But it may not be true. And if they have a therapeutic INR, you're dealing with something else, So I don't know what the answer is. I really do not know. In our place, I think they get an aspirin, pretty much generally. Yeah. So we have a personal testimony, an N of 1. Don't drop over before the end of the talk. You'll ruin everything. Yeah. Yeah. I'm pretty sure that's right, but I can't think of where that's been proven or if it has been proven.
Question, say you do the workup and the workup for reversible causes is negative, does that affect of stroke?
So the question is, supposing you did the workup and it's negative, are they now at lower risk? No. The only reason why you do the workup is because if they have a stroke in the next 2 days and then it turns out they had something that was treatable and you didn't find it and didn't treat it, now you're in trouble. And so this is really, again, I hate to practice for the lawyers, but part of this impetus is somebody's going to blame me if I didn't do it. So at least get the process started. I can't tell you that it's going to actually make it better outcomes. It would, you know, you can imagine an AFib, sure, I'd like to know that, and I bet it would make a difference in outcomes. But the rest of it, I don't, you know, if you're going to have your stroke in the next 24 hours and I find a big carotid lesion, am I going to be able to fix that in the first 24 hours? Is that going to lower the chance of stroke? There's certainly going to be an increase in the acute chance of stroke intraoperatively. So I don't know what the answer is. But in general, the feeling is you can't just ignore it. At least you got to look for something that is potentially reversible.
Two things. One, you can stent it probably within 24 hours now. Just a lot of people are doing that. Second thing is there any data that heparinization would help with tight carotids? No, not.
So the question is, the two things is, one is you might be able to stent this, do it quickly, and that's true. But again, you got to better have a system, and it's not just a matter of saying, well, I knew it, and so I got rid of my own burden. There's got to be a system in place to get this all done quickly if you want to have even a chance of having an effect. And the other is, what about heparinizing them if you found a big lesion? No, I don't know. I doubt it. So that's basically it for TIAs. Any other thoughts, comments, questions?